Hello everyone. Welcome to classes in Pediatric Endocrinology. Today's topic is Rickets, the most common metabolic bone disease. Let us go through the topic in a systematic manner and understand what Rickets is, what are the causes, how do you evaluate, and what is the treatment of Rickets. And we'll discuss a few MCQs at the end. Rickets pathophysiology. What is Rickets? Rickets is a defective mineralization of bone matrix. Did you understand this? Let us go into the detail of each word which I told now. Defective mineralization of bone matrix. We need to understand each of these to understand this disease in complete. Bone is made up of three major components. One is the cells. The cells constitutes the osteoblast, the osteoclast, the osteocytes, and the bone lining cells. And it also has a matrix. The matrix consists of an organic part and an inorganic part. So this is the bone which is composed of cells as well as the matrix. The matrix is here. And this matrix is again consists of an organic part and an inorganic part. The organic part is made up of proteins like majorly type 1 collagen and many other non-collagenous proteins like osteocalcin and osteopontin. The inorganic part is made up of calcium, phosphate, and magnesium. It is mainly a calcium and phosphate called the hydroxyapatite. So you can imagine this as a pillar. So if you want to build a pillar, how do you do it? You need three basic things. One is a metal rod. You take metal rods which will be bent into a particular scaffold that will form the structural framework of the pillar. Then you need bricks which corresponds to the cells, and you need a cement to fix this in position. So just like that, this metal rods corresponds to the organic part, the type 1 collagen. The collagen fibers will be laid down in a particular manner to provide the structural scaffold of the bone. And you have cells, which corresponds to the bricks, the osteocytes, osteoblasts, osteoclasts, and the bone lining cells. Then you have an inorganic part, that is the cement, that corresponds to the cement, which will be filled in between. So this will keep all these components in position and which will add on to the strength of the pillar. So just like that. So defective mineralization means there is a problem with laying down of this inorganic part of the matrix. So rickets is a disease which affects this part of the bone, a defective mineralization. And that affects the strength of the bone. The bone has mainly two functions. One is it forms the structural framework and provides strength and support for locomotion. So that is a mechanical function of the bone. And it also has a metabolic function. It is the largest store of calcium and phosphorus in the body. So in times of need, when the blood calcium is low, it can provide us as a reservoir or a store of calcium which can be released into the blood to prevent hypocalcemia. So it also has got a metabolic function. So it has got a mechanical function as well as a metabolic function. And rickets affecting this defective mineralization of bone, it is called a metabolic bone disease because it affects this function of the bone. Rickets and osteomalacia, as I have told, is the defective mineralization of bone matrix. It is caused by deficiency of calcium, phosphorus, vitamin D, or any regulators of these. Where does this mineralization occur? There are two major sites where this mineralization occurs. Actually, the mineralization is occurring everywhere in the bone. Bone is a dynamic organ and its mineral as well as the organic part is being replaced every now and then to repair it so that it can withstand the day-to-day stress and trauma, which is being micro trauma that it is being exposed to. So till our growth is complete, that is till our puberty is complete by the age of 16 to 18 years, we have a growth, the longitudinal growth, that is a growth in height as well as our bone growth that occurs in the replacement of lamellar bone to maintain the bone. So this mineralization occurs at these 2 points, at the growth plate as well as the lamellar bone, to till our puberty is complete. So once our puberty is completed, then the growth plate fuses and there is no longer height increase after the puberty. So when this defective mineralization occurs in a bone which is pre-pubertal, so till the puberty is complete or the growth plate is open, it causes rickets. Whereas osteomalacia means defective mineralization that affects later also. That is affecting the mineralization of the lamellar bone. So we move on to calcipenic rickets. Calcipenic rickets can also be called as vitamin D dependent rickets. So we have talked about vitamin D deficiency. Now we will discuss the genetic defects of vitamin D metabolism. Genetic defects, as I told, can be classified into VDDR type 1, type 2 and type 3. VDDR type 1 is due to a defective mutation in the 1-alpha hydroxylase enzyme or 25-hydroxylase enzyme, as classified as VDDR type 1A and 1B. So VDDR type 1A is a mutation in 1-alpha hydroxylase and 1B is in 25-hydroxylase. Both these VDDR type 1, both these types has an onset in early infancy or childhood. Both are autosomal recessive mutations and they lead to an early onset and a severe form of rickets. And the child presents with hypocalcemia causing seizures and tetany and requires frequent calcium infusions. And VDDR type 2, it is also 2A is also an autosomal recessive mutation and is a mutation in vitamin D receptor. VDDR type 2B is a mutation in heterogeneous nuclear ribonucleoprotein C1 and C2 protein. These proteins are involved in the post-receptor signaling of vitamin D pathway, and VDDR type 2B is due to a post-receptor signal protein mutation, which affects the post-receptor signaling pathway of vitamin D. And VDDR type 3 is due to activating mutation of 24-hydroxylase, which leads to increased inactivation of vitamin D. The clinical phenotype is similar in all these vitamin D, except for one factor, that VDDR type 2 is associated with a significant alopecia, loss of scalp, body as well as facial hair, so which leads to alopecia totalis. So alopecia is a classical feature of VDDR type 2. So now we move on to phosphopenic rickets. The causes of phosphopenic rickets are mainly FGF23 related disorders. And the common factor in all these disorders is an FGF23 excess. X-linked hypophosphatemia. It is due to a mutation in PHEX gene. PHEX gene leads to excessive production of FGF23 at the level of bone or decreased inactivation of FGF23 at the bone. The exact mechanism of PHEX gene is unknown actually. It was earlier thought that PHEX mutation leads to a decreased inactivation of FGF23, whereas the new concept is that the PHEX mutation leads to unregulated excess production of FGF23 from the bone. One classical clinical feature associated in this X-linked hypophosphatemic rickets is recurrent dental abscesses. So that is a clue to this X-linked hypophosphatemic rickets. And the second is autosomal dominant hypophosphatemic rickets. It is due to a mutation in the FGF23 gene itself. So FGF23, it is removed from the circulation by inactivation, or it is by increased metabolism. And a mutated FGF23 in this disorder leads to a protein which is a super protein, which is resistant to inactivation. There are certain changes in the amino acids of the protein that renders it resistant to inactivation. That leads to FGF23 excess. And autosomal recessive hypophosphatemic rickets, there are two types, two mutations, and type 1 is due to a mutation in DMP1, the dentin matrix protein 1, and type 2 is due to a mutation in ENPP1. It is ectonucleotide pyrophosphate phosphodiesterase. And both these mutations leads to unregulated excess production of FGF23 from the bone. And one classical clinical feature of this autosomal recessive hypophosphatemic rickets type 2 is hearing loss. So if there is hearing loss, then the mutation could be ENPP1. And the next type is hereditary hypophosphatemic rickets with hypercalciuria. Here, there is no FGF23 excess, but this is a mutation of the sodium phosphate transporter at the kidney. Here, the sodium phosphate transporter at the kidney is defective, and so it is not translocated into the apical membrane for phosphorus reabsorption. So, a mutated transporter itself lead to phosphorus wastage. So, there is no FGF23 excess here. Earlier, this sodium phosphate transporter is inhibited by FGF23. FGF23 leads to excess inactivation or excess degradation of this receptor in all other FGF23 excess disorders. Whereas here, the receptor transporter itself is defective, so that it doesn't get translocated to the apical membrane. So, what happens? The mutation is SLC34A3, which codes for the sodium phosphorus transporter type C. And what happens here? Since there is phosphorus wastage and there is no FGF23 excess, so in all other conditions of FGF23 excess, like the XLH, autosomal dominant or recessive disorders, there is FGF23 excess, which has two actions. One, it leads to phosphorus wastage. Another is it inhibits 1-alpha hydroxylase at the kidney, thereby inactivating vitamin D. Whereas what happens here, there is no excess FGF23. So there is 1-alpha hydroxylase activities is normal. So that leads to increased calcium absorption from the intestine, and this calcium is excess calcium which is being absorbed from the intestine is lost through the kidneys. So that leads to hypercalciuria. So hypercalciuria is seen in hereditary hypophosphatemic rickets due to mutation in the sodium phosphate transporter. Then next is hypophosphatemic rickets and hyperparathyroidism due to alpha-klotho mutation. Alpha-klotho, as I told you before, it is a helper of FGF23 at the level of receptor. So it helps the action of FGF23 at the level of receptor. What happens in this alpha-klotho mutation? It is activated. It is constitutively activated alpha-klotho, excess alpha-klotho action that leads to excess FGF23-like situation where there is phosphopenic rickets. So that is, and this another site of alpha-klotho is at the parathyroid gland. So it also leads to hyperparathyroidism. Another cause is Raynaud syndrome, which is a mutation in FAM20C mutation. This also leads to excess FGF23 production from the bone. And another clinical feature which points to the diagnosis of Raynaud syndrome is dental anomalies and ectopic calcification. This is a clinical feature of Raynaud syndrome. Tumor-induced osteomalacia, as I told you before, is due to a mesenchymal tumor which produces excess of FGF23 and leads to phosphopenic rickets. Fibrous dysplasia, it can be either isolated fibrous dysplasia or polyostotic fibrous dysplasia associated with McCune-Albright syndrome. What is the mutation in McCune-Albright syndrome? It is GNAS mutation, which occurs in McCune-Albright syndrome, and this can also lead to phosphopenic rickets. Another is cutaneous skeletal hypophosphatemic syndrome. It is an acquired syndrome due to excess FGF23 production from the dysplastic bone and the skin nevus. Now we look into what are the differences in the radiological features of rickets and versus scurvy. What happens in scurvy? Scurvy affects the bone osteoid, whereas rickets affects the mineralization part. So what happens in scurvy is that the bone osteoid is being affected, and here there is a dense zone of provisional calcification which is called as the Frengel's line, and it can extend to the margins, which is called the as spurs, which are called the Pelkin spurs. And there is a radiolucent area just beyond the metaphysis, which is called the Trümmerfeld zone. And here it is due to vitamin C leads to decreased collagen deposition and decreased bone osteoid. So the major difference is that there will be no widening of physis here in scurvy, because the widening of physis in rickets is due to excessive osteoid deposition. Here osteoid is the defective part, so there is no excess osteoid. So widening of the physis is not there. That is one major difference. And second is that in rickets there is loss of normal zone of provisional calcification, whereas here there is dense zone of provisional calcification called the Frengel's line. Okay. So you can appreciate the differences from here. So there is no widening of physis, whereas here there is widening of physis. And there is a scoring system to assess the severity of rickets called the Thatcher scoring system. It is used for assessing the severity of rickets at onset as well as for follow-up to assess the response to treatment. So now certain clues towards the underlying disease or underlying cause of rickets are there. So rickets, as you know, it is not a diagnosis by itself. It is a clinical manifestation, and we need to find the diagnosis for rickets. What is the cause for rickets? And the clinical signs which help us in clinching the diagnosis of rickets are: one is, if there is consanguinity in family history or a positive family history of rickets, then it could be mostly due to a genetic cause of vitamin D or vitamin D metabolism or a FGF23 metabolism leading to calcipenic or phosphopenic rickets. And any history of chronic hepatocellular failure or obstructive jaundice, it can be due to hepatic dysfunction, and rickets due to CLD. Chronic diarrhea with loose, fatty and foul-smelling stools, rickets could be due to vitamin D deficiency due to malabsorption. Alopecia, as I told you, alopecia is a classical marker of VDDR type 2, that is vitamin D receptor mutation. Predominant lower limb deformities, frequent dental abscesses and decay. It is a it occurs more frequently in X-linked hypophosphatemic rickets. Cataract can be a clue to Wilson's disease, which leads to proximal renal tubular disorder. Failure to thrive, polyuria, metabolic acidosis, hypokalemia, nephrocalcinosis, these are clues towards proximal renal tubular acidosis. Hepatosplenomegaly, hypoglycemia and hyperlipidemia, it points to disorders which can cause proximal tubular disorder like tyrosinemia, glycogen storage disorders, Von-Jex, Fanconi-Bickel syndrome, such syndromes. And presence of acidotic breathing, hypertension, anemia with or without edema, you should suspect chronic kidney disease as a cause of acquired vitamin D deficiency due to acquired defect in 1-alpha hydroxylase. Now, there are certain spotters here for you to refresh. So, what is the first one? Here you can see cystine crystal deposition in the cornea. This is a case of cystinosis. The clinical manifestation is the child presents with rickets and frequent blinking. Here the clue is, it is a cutaneous nevus, large cutaneous nevus and a skeletal deformity. It is a cutaneous skeletal hypophosphatemic syndrome due to excess FGF23 production from this nevus as well as the abnormal bone here. And what is this? It's a large Caffele macule. It's pathognomonic of McCune-Albright syndrome. So, large Caffele macule obeying the midline, not crossing the midline. So, this is a case of McCune-Albright syndrome with polyostotic fibrous dysplasia and excess FGF23 production and leading to hypophosphatemic rickets. Alopecia. This is a case of alopecia totalis where you can see scalp, eyebrows, facial hair, everywhere the hair is absent. So, alopecia totalis and rickets. The diagnosis is VDDR type 2. And this is a PET scan. This is a special PET scan, gallium-68 dotatate PET scan, which shows a tumor here in the skull. You can appreciate the tumor here. And this patient presented with hypophosphatemic rickets. and a tumor. This is tumor-induced osteomalacia due to phosphaturic mesenchymal tumors.